So today we're going to look at a few different models that allow us to quantify more comprehensively the health impacts of transportation planning. But before we go into that, we just want to note that the work today that we're showing is based off a foundation of work that was done both within and without of the Commonwealth. Specifically, we want to tip our hats at a group of researchers that were based at Yale, UMass Amherst, and UMass Medical, who helped calibrate this tool for a Massachusetts regional context, which is really what our work today is based off. So we just want to acknowledge what their work and how it has brought us here today before we get started. Next slide. As we discussed a little bit yesterday, last week, not yesterday, time flies. Transportation and health. So transportation is a social determinant of health, and that's why we think it's important to draw those connections. Social determinants of health are those conditions in which people are born, grow, live, work, and age, and they're the fundamental drivers of health outcomes. So in public health, we often like to think about health interventions as a river. Downstream, we have those approaches that address the individual, like a personalized walking program or a diet. These had and will continue to have beneficial effects. However, they alone are not enough to reduce the chronic disease burden that we are experiencing in Massachusetts and across the country. So for those sorts of influences, we really want to start to look upstream. These are the interventions that can affect the underlying social and economic factors that affect the root causes of illness and can improve health across the population. And these are approaches like building out a network of safe bike and pedestrian routes that enable a community to get active, get around, connect with folks. And it's also the policy and systems that enable that type of infrastructure investment. So the tool why this is important is because the tool that we're talking about today really does its best at measuring those upstream impacts and interventions. And this is important because when we look across a large community and aggregate across the population, we see that the most influential interventions are those upstream ones. So we need to be able to articulate the health benefits in order to advocate for these types of investments and policy making and decision making in the future. Next slide. This is a pathway diagram that we introduced to you last week as a conceptual framework about how we're thinking of transportation, policy, and planning moving towards health outcomes. And what we're really focusing on last week was those pathways, specifically motor vehicle crashes, air pollution, physical activities, and those pathways connections to health outcomes. Today, we're going to talk a little bit about the tools that allow us to look at all of this. There's like this full conceptual diagram. And basically, we're going to talk about how decisions we consider enable certain behaviors that influence what people are exposed to, and then the health outcomes that we see as a result. As we mentioned last week, ITHIM focuses on those three exposures of crashes, air pollution, physical activities, and it also focuses on those health outcomes that have the strongest causal evidence for them. So this includes respiratory diseases, cardiometabolic diseases, mental health, certain cancers, and accidental injuries. And as we dive into ITHIM and health impact modeling in general, you'll see how we stitch all of those together. So with that, I'm going to hand it over to Barry, who will talk a little bit about health impact modeling, then introduce ITHIM in our context, and finally we'll wrap up with an example of what the outputs of these tools look like and how you might use it, the scenarios in which you might use it, and speak a little to what we will do next session.
Thank you, Sharon. That was a great introduction and a great touchback on where we were last week. So we want to start again too, just to kind of go back to the idea of health impact modeling and what that means, particularly in a transportation context. I think we flashed this towards the end of our presentation last week, and this was to give us an idea of other kind of models that are out there, or kind of the range of models that are out there. So you can see a variety of ones: HEAT, Utopia, MAPC, ITHIM, and NFAM. And you can look moving left to right, essentially what are the types of inputs that kind of feed into those. So they're looking at physical activity, air quality, safety, accessibility. In some cases, some of these actually go beyond some of the measures that are noted, but then looking at essentially what the outputs can be. And those are the red and white columns of whether it's talking about deaths, kind of years of living with disability, economic impacts. And if you look at them, the variety of models tend to be some type of comparative risk assessment. And that means that essentially looking at what is the difference between two states, two outcomes, two particular scenarios. And again, you can see there's a variety of different ones, but to simplify it, there's really, it kind of falls into two buckets of impact models. One being a simple model where essentially you focus on one particular aspect of transport impacts. So for example, focusing on physical activity as part of active transportation and kind of where you're having impacts on people's biking and walking for the most part. Looking at that in a very kind of large aggregate, so treating an entire population as a similar group of people who have similar characteristics. An example of this is the World Health Organization's Health Economic Assessment, or HEAT tool. A couple of years back, MAPC and I think CTPS did a health impact assessment when the MBTA was proposing changes to both kind of fares and to service areas too. And the HEAT tool was actually what we used at that point to talk about effects on physical activity and monetization of those effects. Since then, we've actually seen kind of more advanced tools emerge. And these have been able to stay, rather than just looking at one particular option, they've been able to think about various options, or at least more than one option happening within the transportation system. So in addition to physical activity, looking at the effects that increasing or decreasing air pollution has, the effect of safety on the system in terms of injury and death from crashes. And then actually being able to take that kind of large population cohort and break it down into different characteristics, whether it be gender, whether it be age, sex and age, be able to think about and understand that these effects, even though they're kind of in evidence, can play out differently among population groups and among age groups too. And so that brings us to ITHIM, and ITHIM being a place where you see a lot of that information come together and be able to deal both with the independent pieces, but look at them, the complexity and the interaction between the two. So when we talk about ITHIM, we're looking at something that is going to talk about physical activity and active travel has on it, but it's doing that in the context of changes in air pollution and vehicle crashes. It's able to assess these changes that we make, particularly if we think about changing the transportation one that might be more related to a lot of reliance on vehicles for travel, to things that rely upon active transportation as part of future investments. It brings together a variety of different data sources. So it's pulling from health factors, so from state health surveillance systems, from other information around hospitalizations, but it's also pulling from information from the transportation system too, in terms of like how much traffic and travel we have, how many crashes we might be able to do that too. And a great thing here too is that it makes a distinction within the population of differentiating between men and women, as far as we know, in terms of the database and the impact on people's bodies as it works kind of biologically, but then also understanding the effects that each of these things, physical activity, air pollution, and crashes, can have depending on where you are along the life spectrum. And so it gives us the ability to kind of be a bit more nuanced in understanding across the population and how these effects play out. The advantages of ITHIM, and again, as I was just touching on too, it brings together a variety of these things all at the same time too. It gives you ability to kind of make a projection or kind of estimate essentially what would happen in terms of these hypothetical scenarios, were you to make a certain set of investments versus a different set of investments and play them out against one another. You can look at this within specific demographics. Again, like we were talking about, you might want to look how this affects people who are younger, maybe people who are older, a lot of focus on older adults recently too. So this idea, and also too, that it's a comparative risk assessment. As I mentioned earlier, a number of these models are, and so what again, it's looking at essentially what our base case is. And as you make and change these investments, what is the different scenarios that we're running into, and then what do we estimate the health effects would be. It's a spreadsheet essentially that works out, and then Sharon will talk a little bit more of that as we go on too, but at this point in time, it's something that's open source and has been shared and kind of been crowdsourced. And so it's a large Excel spreadsheet that ends up kind of being the model and the way the model works. And it pulls from a lot of publicly data sets too, and that's what forms the inputs and again, the pieces that we can play with. some of the limitations that go into it, because it is such a kind of a large spreadsheet-based model, and I think this is probably the case with a lot of models, there's extensive calibration that needs to be done to really localize where that information is being applied and what's the scenarios that are being played out. There's been a hope at some point in time that this could actually be applied at kind of a neighborhood or even kind of a municipal level, but for the most part, ITHIM is something that operates really well when you have a large population cohort, so something at a county or regional scale. You see benefits of physical activity being kind of paying out a lot more of the value within the system still, mainly because physical activity can have significant effects in the short term as compared to some kind of chronic disease impacts, particularly from things like air pollution that take a longer period of time to manifest. You actually see these net changes that can happen, but it could be underestimating a lot of these other things that we know aren't showing up in the model, such as noise, effects we see from extreme weather and climate change, mental health effects. So it's not actually comprehensive of everything, but we realize those other factors are kind of, and hopefully over time, maybe some of that will be built in. Again, we have to think about whether or not the model and the inputs we're putting in there actually capture those active transportation projects and changes we would think. We know there's some undercounting in the injury and crash system too, so our estimates kind of will be affected by that. But we also know too within this too, we can't necessarily, given some of the demographics, what we have and data that we have, sometimes limitations of the evidence and how they've broken down populations, we may not be able to look at things like race and ethnicity as tightly as we'd like to. And in some cases we really would want to, given what we know from some of the basic studies or anecdotal work that's been going on. So again, that's just an introduction to modeling tools in general and beginning to focus on ITHIM. And so I'm going to dive a little bit deeper into ITHIM to talk about some of the guts of it. Again, still in a conceptual manner, but it's allowing us to kind of drill down layer by layer into ITHIM itself. So ITHIM was a model that actually emerged from the UK, and it's a model that began there first and was used in 2009. Since then, it actually has then expanded to more international implementation. In the US, California Department of Transportation was the first one to really help bring it to the United States. And it did that, excuse me, with the support for the Centers for Disease Control and Prevention back in 2010. You saw ITHIM get its first use. And they use it in California across a number of their different MPOs to do modeling in their work, to apply it within the work that they're doing. And as I mentioned, again, it's an open source project, so you've been able to see expand to other places, Nashville, internationally, places like India and Spain that's been used in those places as well too. And again, because it's not proprietary, it's not necessarily a product you have to buy, there isn't a large barrier of bringing it in that way. But as I mentioned, the calibration piece ends up being something that ends up requiring a lot of investment to do that work. I want to give you an example as well too about where ITHIM has been applied around the world too. So here's some examples and the variations in where it has been used. And so you can see in London and New Delhi, given the size of those cities, they've actually had that scale that's closer to a county or regional scale. So they've actually been able to apply it kind of within a city framework. But in most other places, you can see the examples here in California, in Oregon, in Tennessee, they've actually been at the MPO level. So it's been that larger scale that they've done. You can see across here too, the various inputs that they've used, where they've pulled their information from. So in the case of England, they were able to pull from their health survey. For California, they were able to pull from a behavioral risk vector surveillance system, so like locally collected data. Travel data you pull from the different models, but also the use of household travel surveys. Air quality, you've been able to kind of use both kind of monitoring, but also estimated and emissions that essentially have been projected. And then crashes, they're often pulling from a state crash data set to do that work. And they're then localizing that data to their MPO region, but they're pulling from that statewide data set. So again, this is going back to that example that Sharon was sharing us about the upstream piece, is that we know that the environment that people live in, what that environment looks like affects their behaviors, whether they take more or less trips, and what type of trips they take. We know that behavior then in turn has effects on what people are exposed to, more or less, of air pollution, physical activity, time that they're in traffic. Each of those then has an effect on those health outcomes, and that's where the evidence base is important in establishing those connections to respiratory diseases, chronic diseases, injury, and death. And one of the ways that it really works is using this example of relative risk. And what is calculated is looking at what is the potential for someone to have or experience essentially a worse outcome as opposed to a population that doesn't have that necessarily same exposure. So relative rate really compares the likelihood of a health outcome by comparing a group that is exposed to an unexposed group. For example, if you were to think about it in terms of people who smoke, those who smoke actually are exposed to a lot more smoke than non-smokers. So you can then actually do that and look at both of those populations and calculate the relative risk of something like lung cancer among those groups, knowing the exposure level and what's working. And so ITHIM works in a similar fashion by actually getting at that relative risk, understanding how you change the system and how that then affects those relative risks. Another piece that ITHIM calculates, and we may have mentioned this in last week's, is something that goes beyond just looking at fatalities and deaths. So again, looking at something that's a more sensitive factor of what we're doing. Because when we only look at fatalities, we miss a lot of these things that happen throughout a person's livelihood too. And so ITHIM makes use of a thing called their DALY, or disability adjusted life years. And so the DALY is meant to help us take into account subtle changes in a person's life, such as when they are diagnosed with a disease, how long do they actually have to live with that disease, and then potentially how many years of life lost due to that disease or due to that disability. And that's what essentially goes into our results of here too. And so it takes across how much you could expect, number or incidence of that within a particular population, kind of a score of what it's like to live with that disability, and then the years essentially, most people essentially kind of are the average, it kind of looks like across population to live with that disability, and then look essentially how many people kind of die prematurely, so before the age of 75 within that particular population. And so the DALY gives us essentially beyond just thinking about death and that part of it, but essentially what's going to be affected in someone's life. And so DALY is something that's kicked out of this as well too. So we know, again, there's specific morbidities, so specific things that are going to affect people's life, as well as potentially affect their fatality. And you can see that list here too. When we're talking about air pollution, we're thinking about things such as respiratory infections, cardiovascular disease, a variety of different sorts, lung cancer, respiratory disease itself as part of this too. And so these things you might be living with and things that might actually be chronic, and essentially that would essentially affect you or potentially take you towards death. Similar things with physical activity, a variety of ways that we can see both kind of the cardiovascular disease, the neurological system, even the way different cancers are affected by all that. And then safety take into account both fatal crashes, which that result in death, as well as injuries that, again, would lead somebody to having kind of longer lives with living with a disability. Something that often comes up in the work is this interplay between air pollution and physical activity. And so there's this question of where, if anywhere, would potentially physical activity benefits outweigh or be outbalanced by air pollution. And so this is something, a graph that begins to take that into a point too. And what you'll see on this graph here too is essentially on your y-axis, the kind of relative risk of all-cause mortality. So essentially dying from a variety of reasons. And then on the bottom, the amount of physical activity. In this case, it's talking about cycling and using cycling for that part of it too. And you can see there when it gets to that tipping point, which is around 90 minutes or so, even with an area where you have a background of air pollution as indicated there, 50 milligrams per cubic meter, even in that particular scenario, getting all the way up to close to 90 minutes a day of physical activity by cycling, which is a higher respiratory event, gets essentially kind of greater and greater health benefits. After the tipping point, you kind of level off in terms of those benefits. And then you really actually need to go all the way up to about 330 minutes a day under that background condition, actually where you would see physical activity within that place of pollution actually resulting in worse health outcomes. And that's where your kind of break-even point, the physical activity doesn't really do any additional help for you too. And so as we look about these things in concert and together, we begin to continue to see that physical activity on its own belays a lot of kind of benefits and health benefits over a lifetime, even in places where there might be high levels of air pollution. So hearing all that and bringing it all together, you can see essentially where we begin to put all these inputs into ITHIM. And so working from left to right, we're getting information about the population, as I mentioned, age and sex. We're learning about disease-specific deaths, so essentially how, both kind of by age and by sex, how those deaths might be experienced differently. Disease-specific dailies by age and sex to give us a sense of disease burden. We're bringing in travel time, travel data, so travel time, travel distance, vehicle distance traveled. We're getting information and measures around physical activity, what the background air pollution is like in those different scenarios, and then ultimately essentially bringing in those vehicle injuries around serious and fatal injuries. Working from that top line of those colored boxes down one layer, what that allows us to do is establish a baseline ITHIM model. So that allows us to know essentially what those experiences and what those conditions are like under the current scenario. When we run ITHIM, what we're then doing is beginning to bring in inputs that create us an opportunity to shift the travel scenario. And what that then allows us to do is to do that understanding of what does the new travel scenario look like against the base travel scenario. And that's where we see the delta of the health effects that we're seeing there. What is happening in terms of mortality and morbidity. And then that comparative results tell us when we might want to make different investments and how we can consider those investments having an impact on the system. When it comes to Massachusetts, there's a number of different data sources, and this gets to the local calibration of it here. So you can see those inputs that match up with the boxes that we just showed on the previous, or that are aligned with the boxes on the previous thing, on the previous table. The sources of where we're pulling that information, so things like the census, a number of things are coming from the household travel survey. Hopefully we'd have a more up-to-date one because that's probably lagging the most at this point too. Pulling from information such as models, such as the air quality model from Harvard. Something that may not be as familiar with the work that you do is the Massachusetts Behavioral Risk Factor Surveillance System. And so this is a self-report survey that's done typically annually or sometimes aggregated over a series of years. But that gives us essentially a better sense of things around physical activity to account for non-transportation physical activity elements. So these are the things that have been used to calibrate and to kind of set up ITHIM so that it would work well for the MPOs within Massachusetts. You can see again here, this is to give you a sense, and I think you're probably way familiar with this, particularly the purple one in terms of Boston MPO, but these are the different geographies by which the calibration has been done in Massachusetts. So hopefully that's given you, again, kind of some anchors to think about how the ITHIM pieces all fit together, what's that data that's coming in, how it's feeding together to give us that base scenario, and then thinking then about how we will make alternates off of that base scenario to understand what is the difference if we were to make some decisions and make some different investments. With that, I'm going to turn it back to Sharon to kind of walk us a little bit more into ITHIM action in action.
Thank you, Barrett. So I wanted, before we move into, we have the high level understanding of what's the guts of ITHIM, but before we move any deeper than that, I wanted to give you some insights into what the capability was of this model. So to what Barry just gave as an overview where we had this baseline, given an example of a comparison scenario and see what are the outputs that this model creates, that it gives us the data that compares the baseline to the new scenario. So next slide. Today's example scenario comes from the Mass DOT's Green DOT Implementation Plan. This was a plan published in 2015 that had a vision for the state for tripling the share of travel in Massachusetts by bicycling and walking by 2030. While this was in the context of greenhouse gas emissions, part of this vision statement was set in the context of achieving positive public health outcomes. So when we're looking at this scenario, we want to articulate and quantify what exactly those public health outcomes might be for achieving this scenario of tripling the share of biking and walking. So Barry, if you, next slide. So if we were to achieve, this is setting us up for moving into ITHIM about what are the inputs that we are putting into our model. So we are adopting the Mass DOT's 2012 Green DOT mode shift goals. Specifically, we're looking at what the impacts are on morbidity and mortality if walking trips were to increase by a multiplier of 3. And the last bullet point is speaking to within ITHIM, you have the opportunity to adjust the percent of car miles that are substituted for other modes when you're increasing them in this way. So we could look at a scenario where 100% of those 100% of those bike and walk trips are replacing car trips. which would imply that the baseline total per capita mean miles traveled over all modes would remain unchanged. However, in this case, we're assuming that to achieve the Green DOT's goals, there are also going to be infrastructure changes that will replace these longer car trips with shorter ones by bike and foot. So to modify our assumptions a little bit more, we want to hold the number of total car accidents or accidents from traffic to be constant. So we're going to offset where we know that active transportation has an increased rate and risk of traffic-related injury and deaths. We want to offset that risk by reduction in VMT. So I'm going to show at next meeting, and we'll send out a video after, of us editing the workbook to reflect these different scenarios, these different inputs that I just laid out here. But today we're just going to jump straight to the outputs of this model. Next slide. So this is an example of what comes out in the travel summary page of ITHIM. And this is just reinstating that we entered these assumptions correctly. So you see here, click one, that we set out to triple the number of active transportation trips, and that has been done. So this is calibrated specifically for the MPO. Based off this baseline calibrated data, the model estimated that per person per year, about 150 miles were being done by active transportation modes prior to achieving its goal, which would increase to about 460 post achieving this goal. Because we wanted to hold that level of fatalities and serious injuries due to traffic accidents constant, we're seeing that the distances that people are per capita that is being done per year are also dropping. And that's on the left when you see those bars dropping below. So we're looking at the gray box and that yellow box on top as the car distances that are dropping. And we're seeing that in order to hold these fatalities and serious injuries constant, that we're dropping from about 12,000 miles to 10,250 miles per person per year. Since this scenario didn't include any assumptions about changes to buses and rail usage, you'll note also on that left graph that none of those proportions, none of those amounts shifted. Next slide. Again, to give you a better understanding and to reiterate how we looked at holding the total number of fatalities and serious injuries constant, this is an example of what comes out of the ITHIM health outcome that allows us to look at in our baseline and our user-defined scenario, so that triple mode share scenario, what are the estimated fatalities and serious road injuries by victim mode. And we see here we wanted to hold the total constant, so it was at 1739 for the MPO region, and we wanted to keep it at that number. Barry, next, click one. Oops. So due to the increased relative risk for active transportation modes for road injuries, you're seeing the increase in biking and walking totals of traffic accidents. So we had to drop the number of VMT to have the car mode compensate for that increase. Next slide. This is looking beyond just those road traffic injuries, and this is the power of ITHIM. So speaking to what Barry was showing about how we're putting all of these inputs and we're looking how they influence each other, you can see that as we spoke to, the net benefit of increasing active transportation is high. So everything that is to the left of our center line represents net losses in death from the baseline to our user-based scenario. We're seeing that the majority, well, all of those benefits are coming from the increased physical activities that we expect. And these are benefits to those cardiometabolic diseases that we described before. So stroke, heart disease, hypertension, dementia, diabetes, and colon cancer and breast cancer. But we're also seeing that with this increased after transport, there are increased risks for air pollution exposure and traffic-related injuries. And as Barry spoke to with that graph that showed us this is the tipping point, we don't expect that those increased exposures to offset the net benefit of physical activity. But ITHIM allows us to tease that out a little bit more and see the different influences of these different exposures on our net disease burden. So this is mortality, but we also spoke to the fact that one of the reasons why we like working with ITHIM so much is that it allows us to get at this more sensitive measure of disease burden, and that's the DALYs, to really understand the effects of these decisions over the course of a life. So if you'll click next slide. You'll see here that the direction of influence when we look at disease burden is similar to what we saw in mortality, but that the magnitude is much greater. And that's especially true when we look at respiratory diseases, but also true when we're looking at, again, those cardiometabolic of heart diseases and diabetes. Next slide. So the example that I just gave you, and this is to say, so the inputs that I described up front, those assumptions, that defines what type of scenario that we were comparing to that baseline calibrated data. The example that I just provided to you was an example of a mobility-based user-defined scenario. And this is the type of information that you might get from either vision statements or scenario planning. But this is just one example of the different types of capabilities that ITHIM has. So you can also use as input health data. So this is looking at what if we were to have a new transit station in this neighborhood that were to increase the number of active minutes that folks were walking every day from 15 minutes to 32 minutes. And so we can put that into ITHIM and see what are the health benefits of that increased walking time. We can also use the inputs for ITHIM as outputs of travel demand models. So this would be a predefined scenario. So you're taking the outputs that are coming out of travel demand model or maybe a tip and putting it into ITHIM to say, if we have all of these predetermined VMT, amount, mode share, what would we expect to be the health outcomes? And so those are examples of that. We'll give a little bit more in depth next time we meet. But we just wanted to indicate that this example, the outcomes are very similar to what we saw today for this user-defined mobility-based scenario. But the way that you use the tool and the inputs that you put in change a lot depending on what scenario you're going into the tool with. Next slide. So these inputs can come from lots of different sources. Again, the one today reflects more of a scenario planning or aspirational, but we can also have inputs that are based off literature. So there is literature looking at the relationship between transit usage and increased walking and biking. So we can say if we're increasing transit usage, the literature tells us that we expect biking and walking to increase by X minutes. What are the health inputs, health outputs of that increase? And as I mentioned, you can also look at travel demand model outputs as inputs. And ITHIM is really interesting, especially when you start looking at scenario planning, because then you can start looking at the sort of aspirational multipliers that I described today, but also looking at estimates based off population and built environment data as inputs. And you can play with all of that within the tool itself. Next slide. So after today's meeting, a little bit later this week, I will send you a recording of how I modified that Excel worksheet to get the output graphs that I shared with you today. This is just a screen grab from what I was modifying to do it. And next week, we will go through for each one of those different scenario types, how you might modify these spreadsheets to get those health and travel outputs. To do so, we are going to be joined. It won't be Barry and I alone next week. It will be we will have representatives from that research team that helped us calibrate this tool in the first place. So in addition to sending you the video of me modifying, I'm going to also, the team will send you also a set of spreadsheets for the MPO, MPOs in the state, user guide, and a couple of scenarios, including the scenario that we talked of today with a little scenario tutorial. So if you want to look through any of those in advance of next week's meeting, and come prepared with questions, whether it be to how do I use it, to this tool, to how did we calculate this, enables you to do a little bit exploring to come prepared with those questions if you have the time and interest. Next slide. So with that, that is our overview of ITHIM, what goes on conceptually inside it, and what might come out of it once you start playing with the different scenarios that you put into it as inputs. So thank you for attending. We will open up for these last 20 minutes for questions, comments. And so with that, I will hand it over to our facilitators.
Thanks, Sharon and Barry. That's really great. So we now obviously have time for some questions. So if anyone wants to raise their hand or type a message in the box, we'll give you a few minutes or seconds to do that.
If anyone does want to ask a question, just raise your hand or type it in the chat box.
I'll start with a question, maybe help people get their thoughts going. I was just curious if you knew with the slide, Barry, that you showed the the tipping points regarding the influence of the combination of active transportation and PM 2.5, and how that affects health. I was just wondering, I think on the slide it said the background PM 2.5 was like 50 something. And I was wondering if you had a sense of like how bad that is. Is that like Boston area levels, or how, like, is that not bad at all?
That's a good question. I guess I wouldn't be able to share, but someone on the phone might know better than I for this area. But I do know that when they look at essentially kind of the average PM 2.5 concentration across the World Health Organization has a database globally. I think they tend to say the average is somewhere in the range of like 25 to 30, I believe, with the 99th percentile of PM 2.5 globally being around just shy of 100. So 50 would be essentially kind of, I think, at least globally, a little bit of a higher concentration. And 50 essentially being kind of below what would be or 50 being above what the kind of the world average is too. So it's something that could even be elevated. It's even being conservative and having a more elevated level of background air concentration. I think the thing I will note here is, and we've done some work around like ultrafine particulates, and I think the graph Sharon showed last time too, that is kind of a background thing. And so you're kind of, that's why the larger geography is important, because we do know some of those kind of localized effects as it sits around a particular roadway might be different or experienced differently too. And so that's part of, again, I think some of the limitations of understanding, and that's why that scale is important.
Thank you.
Maybe to pose a question back to you all and to others on the line too, kind of curious what thinking comes in mind in terms of how something like this might be applied and what value it might have within the kind of MPO conversations that you all are engaged in.
Be interested to hear what folks on the call have, and our attendees have to say. I know what I think, but anybody have any opinions, thoughts?
They're all shy.
Kathy, I'll unmute you.
Oh, there we go.
Okay.
Well, I guess I can just chime in. I don't know if this is, I'm kind of having a delay here. So this is, so we're in the process of doing, for the long range plan, we're going to be doing scenario planning. We're just starting to get into that. So there's possibly ways that we can include this modeling as part of the scenario modeling that's done for the long range plan. We're doing some work now to see what tools are out there. So I know Bruce, and is Bruce the only one, and Jay Ping from the modeling group. Maybe this is something, I'm not sure if you're looking at this to include as part of your work with others, other projects that you're working on. But we could potentially use it for the long range plan.
Yeah, thanks, Anne. I'll go to Kathy now. You're unmuted.
My picture went away. Okay, I'm looking at this model and seeing that you want to do it on a regional basis, and so, but all the remedies are small areas. People walk and transport, not too many people bicycle and walk this whole area. So the effects should be considered under small areas, I would think, but how do you handle that so that, you know, you get the right results of this area improves the whole, but this is where we need to work first. Does that make sense?
So Kathy, I think what you're saying is that it seems as though ITHIM is applied on a really large regional scale, but a lot of the work that or a lot of transportation improvements involve smaller segments, and when people walk and bike, it would be a smaller trip. And so you're wondering how to kind of balance that?
Yeah, how to go after a regional model getting to the best area for the first fix.
I think that's a really great observation. I think it's often been a question that we've had around ITHIM too, understanding kind of the great outputs it can provide in a kind of more holistic way, or at least kind of the various ways the transportation system can contribute to health outcomes. I think the way I've come to kind of look at it and think about it is it tells us to some degree it can tell us in aggregate what we need, particularly if we're thinking about particular health outcomes. And so it's a way, I think, potentially of thinking how we might, what's the total amount that we want to program if we're going to achieve some of these outcomes, whether it be essentially kind of facilities for transit or facilities where people can bike and walk, and then be able to use that aggregate to think and compare with our contextual information that we know, or local information, to say, like, here are good places to put that information. And there's actually some really good research and literature talking about kind of those associations, both from the transportation and the health side, to say, like, what types of changes are more associated with greater levels of physical activity. And so you can kind of reverse engineer what contexts are really good for that, or what changes could happen in a particular context to make that possible. And so I think to some degree it's in the absence of a local understanding the aggregate, and then figuring out how you might apportion that across a larger region in order to kind of get that cumulative outcome you're looking for. So one way of saying, I think you're noting a really important limitation, but I think there are potential ways to use the model to help manage where you spot place those things. Yeah,
well, you used to talk about acid rain and coming from the coal-fired power plants in, you know, the mid-Atlantic, I mean the Midwest area.
Yeah,
thank you for that, Kathy.
And Kathy, thank you. Well, definitely, we can, you know, that's one tool. You know, there may be others that kind of get at what you're looking for at a more project level.
But looks like Bruce also has his hand raised. Should I allow him to talk?
Yeah, absolutely.
All right.
Why, thank you. allowed me to talk. Okay, so I guess part of one of the questions Kathy sort of asked that I had in that, is there a good way to translate this sort of, you know, thing down to a more disaggregate level? Because again, despite the fact that we have a regional model, often we are called upon to look at something specific in a specific area and, you know, make changes in this one little, you know, kind of corner, shall we say. And well, you know, how do we, you know, overall, you know, people, how do I think it? We have a lot of clients that don't like to think regionally, you know, and I guess figuring out a way to translate that, which you sort of, I guess, talked about with Kathy, but I'm specifically, I mean, you know, someone is going to say, oh, I want this in this space right here. What's the impact of that? How many more people are going to die or won't die? I guess is one way to, you know, kind of ask, as opposed to thinking regionally. And I don't know if, you know, in your experience, you know, you've managed to figure a way to say, aha, well, all right, you know, these communities are, you know, we can set an overall parameter, but then somehow there's a sub-model that we can look at these communities over here, and which have slightly different characteristics and that sort of thing.
So I'll just say that I think that's a really great observation, and can absolutely totally sympathize to it, being from MAPC. So I can completely agree with that those arguments. So I think two things that sometimes can be helpful in that regard too is that while we're talking about ITHIM, I think going back to that set of models that we introduced earlier, the Health Economic Assessment Tool, or HEAT tool from the World Health Organization, I think can allow some of that kind of lower scale things. And then the second piece, Oregon, so as I was pointing out, different places have played around with ITHIM. Oregon has an interesting model too, where they use some like pre and post self-report surveys to somewhat localize the ITHIM model too. And so they have a specific tool that can allow them to get a little bit of a lower scale. So for example, like maybe either tested or piloted a transit or shuttle line in a particular area, and you do a kind of a pre-post, hopefully get kind of some consistent self-reporting and all that in terms of who's reporting back. But that's also a model too that can do a local adjustment. I think overall, and we may have touched on this a couple times too, is even though you can get more nuanced, both because of the research, but because of the strength of the research, the physical activity benefits are something that just kind of give a lot of both kind of health protective factors, but also kind of prevent a lot of other health disease. And so often the more local you get, that's what you really tend to see the great effects coming from.
I have another question. I guess and I guess it's just maybe my, you know, not being familiar with the literature. Is the public prepared to see that those graphics where it shows increases in sort of deaths from, you know, certain kinds of physical activity? And again, overall, it balances out, but I guess it's just a question of, you know, well, you know, overall, you've lowered this, and this, but aha, respiratory stuff is up. And I would say, you know, as someone who doesn't necessarily go in front of the public, I could say, well, you know, okay, this balances out and whatever, but, you know, people expect a certain narrative, and I guess I'm curious if like the folks who developed this, or even you guys have figured out a way to kind of frame this other than, well, it overall balances out, because I can, again, just imagine a whole bunch of people, you know, reacting poorly to this, seeing that, you know, it doesn't all go in the right direction, shall we say.
And I'll shut up after this, and if others want to answer, but I really appreciate that observation, because I think that is a key point of this. And I think it's actually very relatable in the current moment that we're into around COVID too, where a lot of the answers that people have to provide, or the information that's most helpful, is very kind of nuanced. It's not all good, all bad, but it's this kind of risk and spectrum on which we're doing. And so I would imagine that we'd probably run into some of those barriers that you're highlighting. And I think I appreciate you flagging it because it does speak to that. We're trying to talk about on balance where it lands us, but understanding and hopefully being candid with people to say that if we get more people biking and walking right away, that is associated with an exposure for more potential injury and risk to people who are more vulnerable as road users. And so doesn't mean we can't get over that hoop, but that doesn't mean that everything becomes glorious the moment people walk and bike more in a system that's not built yet to be that way.
Yeah, I think, Bruce, that's a super good question. Like, I think that is something that we deal with outside of ITHIM, obviously, as you know, when we do any modeling or any project evaluation, is how do we communicate with people that every project is going to have good and bad things associated with it, and especially sensitive. I can imagine it being potentially very sensitive when you're talking about like actual reporting deaths and like, you know, injuries. So I think part of it will be on us as an agency and the staff to think about how we communicate the results, because that gives you so many different, very useful and interesting charts that we want to communicate that all. Do we want to aggregate it more and give more aggregate information to the public maybe? And also in thinking about like, okay, so maybe there may be more crashes, like Barry said, potentially if people are starting to bike and walk, but then like knowing that, what are kind of the steps we can take to intervene before that happens, knowing that this project hasn't happened yet, this is all like projected in the future. Maybe we think about, okay, then we need to be more proactive in programming projects that protect bicyclists and pedestrians. So that might be one way to think about it.
I think that's exactly right, Betsy. And I was thinking both to answer two of your questions. And I've seen interesting uses of ITHIM in health impact assessments, which allow you to capture both those positive and negative health impacts and then provide recommendations towards both. And so I think it's acknowledging and owning these negative health impacts and where there is possibilities of mitigating some of them, providing suggestions on how to do so, even if it's not within your current decision-making influence, but acknowledging that this is something that someone else should explore given the intended outcomes. And part of that is noting to your first question, Bruce, of where we want to see more local data. A lot of the limitations on ITHIM as it's currently calibrated are due to the scale at which we have data. So I've seen in that people have used it for health impact assessments on smaller scale projects. I've seen interesting usages of collecting, say, local bike and pedestrian data before and after, and collecting their own small scale physical activity data to allow them to do a little bit more of these smaller scale estimates. I mean, to Barry's point, physical activity ends up really driving even at these smaller scales. But there are ways around that just this current tool is calibrated at a regional level, but that doesn't mean you couldn't calibrate it with different data at a smaller level.
Great. Thanks. Appreciate it.
Thank you.
Any other questions before we sign off for the day?
I see a couple raised hands.
Oh, thank you. I think it's just Bruce and Kathy. Unmute or unraise your hand, that would be helpful. Kathy, do you still have a question?
Yes.
Okay, go ahead.
I'd like to see a scenario here of how people who live far away from their jobs make use of this, because you can't get, you can't walk 25 miles to work, or you can't bike 25 miles to work. What are the examples of how you fit this physical activity in for that kind of scenario? And that's a regional scenario.
That's a good point too. And I think to touch on one piece too, one of the things that ITHIM is trying to account for is kind of your whole daily physical activity. So it includes both kind of the commute-based physical activity, but it's also trying to make an account for all the other things that we do during our day, walk around the neighborhood, recreation, or walking to a park, or going to go shopping. And so it's trying to account for those other types of physical activity pieces that happen within it too. And so I think to your earlier question, for example, a scenario that's been going through my mind is if we're practicing a lot more physical distance, we may not necessarily be congregating in a central business district anymore. What does that mean if you have to then end up having stronger kind of neighborhood business districts? And what effect might that play out in terms of physical activity? So if we were to allot those investments to more kind of lots of small centers as opposed to a single large center, is that a way to kind of play out a physical activity scenario or an ITHIM scenario as we think about where those infrastructure investments could go?
Okay.
Okay.
Note,
Go ahead.
but I also wanted to share, so Anne had mentioned that this could possibly be, there seems to be conversation, but this could possibly be used for scenario
And it
planning.
could also, you could be switching from driving to transit and walking to transit.
Yeah, yeah, an important, yes. But noting that the slide deck that I will send you out has an example after that end slide of a city that did exactly that. They took scenarios for scenario planning.
I'm having technical difficulties here.
And so if you're interested in looking at what that might look like, feel free to flip to, I believe it's slides 44 to 47, which is an example of a city using ITHIM to test scenario planning. Okay, and that was just my final note.
Okay, great. So thank you all. We'll be back here same time next week for the final presentation. And you can expect to see a recording of this video and some follow-up materials if you want to review them, as Sharon mentioned. So thank you all for coming, and hope you enjoy the rest of the afternoon.
Thank you all.
Thank you.
See you soon.